Now, coming to what is extracorporeal treatment for poisoning, it is heterogeneous group of modalities to promote removal of toxin and to support or temporarily replace the function of vital organ. Although poisonings are common and counted in emergencies, but extracorporeal modalities are required only in 0.1% cases of poisoning. And what are the indications? And sharing, stop sharing. Sharing. It's visible now? Yes. Okay. So, just again, I'll repeat. There we will discuss three cases of poisoning in which extracorporeal treatment is frequently required. So, coming to what was extracorporeal treatment of poisoning, it is heterogeneous group of modalities to promote removal of toxin and support or temporarily replace the function of vital organ. So, these modalities are used. Slide screen करने पे नहीं आ रहा। नहीं, ऐसे ही कर। Okay. Now it is visible. Video on. Okay. Yes. So, extracorporeal treatment, although poisoning is commonly encountered in emergencies, but this modality is usually required in only 0.1% cases of poisonings. So, first successful in vivo experiment with hemodialysis was carried out in 1913. Removal of salicylate from poisoned animal. Now, this extracorporeal treatment in management of poisoning remains a topic of controversy and uncertainty whether when and how it should be used. So, a multidisciplinary, multinational collaborative known as extracorporeal treatment in poisoning has been formed and aimed to clarify the role of extracorporeal treatment in poisoning. So, what are extracorporeal techniques? These are hemodialysis, normal hemodialysis, then other is high cutoff hemodialysis, then continuous renal replacement therapy, hemoperfusion, plasma exchange. And what is the difference is that what is type of toxin we are dealing with. If protein binding is less, then high cutoff hemodialysis or hemodialysis is used and CRRT is used. But protein binding is high or the protein molecule is larger molecule, then we need hemoperfusion or plasma exchange. So it is depends on protein binding, volume of distribution, and size of the molecule. So molecule of smaller size are removed with hemodialysis, a bit larger by high cutoff, then a bit larger by CRRT, and by hemoperfusion or plasma exchange, we can remove any size of toxin. So what is hemodialysis? It is displayed in this cartoon. We can see this is a dialyzer, artificial dialyzer. And what we do is that we connect with the large bore vein. The vein should be large for adequate flow of blood. And from one side, the blood is taken from the body into the dialyzer, and here the dialysis occurs, and the filtered blood is returned into the body. And what happens is blood flows from one to other side, and this is dialysate. And dialysate flows from one to other side, and here the exchange of toxins or any substance which is higher concentration in the body occurs, and it is gets filtered out and drained out from the body. And what is hemoperfusion? In hemoperfusion, there is no dialysate is there. You can see on the other side, only a cartridge is there, which is embedded with resins. And when blood comes in this cartridge, the toxins bind to that resin, and the filtered blood is then returned to the body. And this is how plasma. What is plasma exchange? It is now plasma exchange is also where there is no flow of dialysate. What is this? There is plasma filter is there, and plasma filter, blood from the body comes into the filter and it is filtered, and the filtered blood is returned back to the body. This is hemodialysis machine. We will show you live after a few minutes. So principle of toxic removal are: the ideal dialyzable substance should be small molecule, low volume of distribution, low protein bonding, and rapidly redistributes from tissue to plasma. So it will be dialyzed very fast with hemodialysis. Now the volume of distribution is theoretical volume, that how much substance is present in plasma, because the substance present in plasma can only be filtered through these dialysis modalities. So if the substance is widely distributed in the body, then only small amount of poison present in plasma can be removed. So solids with volume of distribution more than 1.5 liter per kg are poorly amenable to extracorporeal removal. Second is protein bonding. Almost all solids are protein bound to some degree, and plasma protein that binds to drug, then the size becomes too large that it can be removed by extracorporeal therapies. And the fraction of toxin that protein bound are not removed via hemodialysis. Substances with less than 80% protein binding are typically amenable to extracorporeal treatment, that is hemodialysis. So protein binding is also saturable. So after some point of time, some amount of drug will be free in the body, which can be dialyzed from the plasma. And the third is toxin size. So conventional dialyzers, as we showed in the first slide, remove smaller, less than 15,000 Dalton. Higher cutoff filters remove up to 50,000 Dalton size. And plasmapheresis or hemoperfusion can clear molecules or poisons of any size. So size of the protein binding and size of the poison, molecular size of the poison determines which modality of extracorporeal treatment we should apply in that patient. So distribution into plasma: as toxins are removed from plasma, they diffuse from the tissue along the concentration gradient. So what happens after dialysis session is complete? There is um, that substance or poison which is present in the tissues will come back into the plasma, and that is called rebound phenomena. This happens when volume of distribution is very large. And the example of this rebound is lithium. So coming to choice of therapy, one is intermittent hemodialysis, which is not very costly, very easily available, and it is useful for low molecular weight poisons can be removed with low volume of distribution. Second is hemoperfusion, in which the blood passes through the charcoal coated cartridge, and it can remove any size of poison, but hemoperfusion cartridges are very costly and there are side effects. The disadvantage like thrombocytopenia, leukopenia, hypocalcemia. Very large amount of anticoagulation is required, so it exposes risk of bleeding. Cost: resins are not easily available, and resins may not bind all the toxins. So it is very less practice, and it is usually used for paraquat poisoning. Now coming to plasma exchange, this is also a modality in which any size of molecule can be removed, and toxin clearance can be done by, if large uh, molecular weight poison is there, it can be removed by plasma exchange. Now how to do this extracorporeal treatment? We require vascular access. Types of vascular access we will just display from our dialysis unit. Choice of dialyzer: filter, high cutoff, plasma filter, or hemoperfusion. This is decided according to the poison characteristic. That is three parameters: volume of size, protein bonding, and volume of distribution. Anticoagulation, usually heparin is there. Dialysate composition is as equivalent as plasma, and duration is 3 to 4 hours. Now, blood dialysate influent, these should all be maximized according to the capability of the machine. Dialysate composition is as per plasma. Now, indications: exposure of poison likely to cause serious morbidity and mortality. As I already told in the first slide, that only 0.1% poisoning cases require this modality, and these are usually indications. The other could be toxicity unlikely prevented or reversed by antidote. Poison toxicity unlikely to be minimized by treatment that prevent absorption, that is gastric lavage. Poison's endogenous clearance is less than 4 ml per minute, and volume of distribution is less than 1 to 2 liter per kg. So this is slide we can see. We, before considering extracorporeal treatment, we should have the following questions to be answered. Is exposure to poison likely to cause serious mortality and morbidity? No, then ECT are not indicated. Can the poison toxicity be prevented or reversed by antidote? Yes, no need of extracorporeal treatment. Can poison toxicity be minimized by treatment that prevent absorption and enhance elimination? Yes, extracorporeal treatment not required. If endogenous clearance of poison is more than 4 ml per kg per minute, yes, then extracorporeal treatment not required. If poison volume of distribution is more than 1 to 2 liter per kg, yes, it is not required because it will not be effective. If these answers are no, then we should now think what percent of poison is protein bound. According to this, if more than 95% protein bound, then plasma exchange is required because the volume will be large. If it is less than 80% bound, then what is molecular weight of poison? 15,000 hemodialysis, 15 to 25,000 hemofiltration, 25 to 50,000 high cutoff hemodialysis, and more than 50,000 it should be plasma exchange. And if it is 80 to 95% protein bound, then hemoperfusion, that is cartridge, is required. So this by this way we can decide the modality of extracorporeal treatment. So coming to case 1, that is methanol poisoning. The usually toxic alcohols are methanol, ethylene glycol, isopropyl glycol, propyl glycol, and diethyl glycol. And they are usually small molecular weight, and the clinical features are almost similar in these poisoning. So methanol is metabolized by alcohol dehydrogenase into formaldehyde and formic acid, which is toxic. So although alcohol dehydrogenase inhibitor fomeprazole is commonly used to treat this poisoning, if it does not remove these toxic metabolites, and if volume concentration of methyl alcohol is high, then we need dialysis to clear it, or if patient presents with blurring of vision, that CNS symptoms. So indications of treatment in methanol poisoning are severe metabolic acidosis, methanol concentration more than 50 milligram per dl, or more than 70 milligram per dl if treated with fomeprazole, deteriorating vital signs, or AKI. Now coming to salicylate poisoning, it is usually caused by aspirin ingestion, more than 100 to 150 milligram per kg. If it is taken, and then poisoning will occur. It presents with respiratory alkalosis, and complaints are usually confusion and agitation, hyperventilation. Treatment is volume resuscitation, oral activated charcoal to prevent absorption, and alkalization of urine. Now, what are indication of hemodialysis? If concentration is more than 100 milligram per dl, if 90 milligram per dl, but AKI is there, if 90 gram per dl after IV fluid and adequate water resuscitation, if more than 80 milligram per dl after volume IV fluids and alkalization of blood, or patient presents with respiratory distress. So metabolic abnormality and respiratory abnormality are commonly indication of dialysis in salicylate poisoning. Intermittent hemodialysis is preferred method because it's small molecule and can be easily filtered. CRRT if patient is hemodynamically unstable. Now coming third to lithium toxicity, it is used in panic disorders, psychiatric disorders. It has very narrow therapeutic range, and toxicity could be acute or chronic. And acute toxicity usually occurs with overdose. Hemodialysis is effective because it is a small molecule. But one point is there that there could be uh, rebound of this lithium after dialysis. So next session may be required after few hours or next day only. CRRT if patient is hemodynamically unstable, otherwise hemodialysis will be is a treatment of choice. And after each session, we send lithium levels whether our target is complete or not. So this is slide where common drugs, what drugs toxicity and what is modality used, and it can be easily found. You can online: acetaminophen HD, barbiturates HD, carbamazepine HD, dabigatran HD, lithium. Most of the drugs can be removed by HD. CRRT only when patient is hemodynamically unstable. So, in short, the take home message is first assess the risk. If patient of poisoning comes, whether it requires extracorporeal treatment or not, assess risk. Is exposure of poison likely to cause clinical toxicity? Is toxicity expected to be reversed or prevented by non extracorporeal therapeutic measures? Does poison have an endogenous clearance high, or benefits of is extracorporeal are expected to outweigh its risk and cost? So if these indications are fulfilled, then we should go what is poison molecular size, what is protein bonding of the poison, what is molecular size of the poison, and what is volume of distribution. So these will decide. Smaller size, dialysis is effective. Less protein binding, hemodialysis is effective. Middle size, high cutoff dialysis or hemofiltration is effective, and larger size plasmapheresis is effective. Thank you. This was just a brief about what are indications and how we should decide extracorporeal treatment. And next, we will follow in our hemodialysis unit what are types of vascular access, how the machine works, and what are the filters that we use for dialysis. Thank you.
A very good afternoon to one and all. Now, after Sir's lecture, we'll just take a brief look at the various practical aspects and the modalities which Sir have taught us. Coming to the first, all the instruments which are used and various components used in a dialysis unit. First, we discuss about the various filters which are used in removal of poisons. This is a high flux. This is a high flux hemodialyzer. This is used for mainly large particles, around 15 to 25 K Dalton. This is a dialyzer medium flux, which are normally used in our dialysis unit, mainly used for clearance up to 10 K Daltons. Similarly, a same set but for pediatric population, and a flex dialyzer, that is plasma exchange, for use for plasma exchange, in which there is no size cutoff because we change the plasma of the patient. After selecting the dialyzer, we go for access. Since it is a case of a patient coming to our emergency department, we need a temporary access. For temporary access, we put a single lumen, single lumen, single use disposable femoral catheter. However, if we anticipate a longer duration of However, if we anticipate a longer duration of use, we put a double lumen catheter. For longer use, we prefer internal jugular access, followed by femoral, followed by subclavian in severe cases. If we have a patient with AV fistula, which is a permanent access used in patients of CKD, we use cannulation units for cannulating AV fistula or graft. This is a 17 gauge fistula needle and syringe, and this is 16 gauge. In HDF and dialysis unit, the dialysis solution is composed of two basic solutions, solution B and solution A. B consists of bicarbonate and A consists of citrate, that is like sodium, magnesium, and calcium. Now we'll take a look at a patient who is undergoing a dialysis and understand how a machine functions. After taking proper consent from the patient, we will be examining him. Here we can see a patient is already a patient of CKD who have made a AV fistula in his left forearm, in his left arm. This is the red end, that is arterial end, which is connected to the machine. And this is the dialyzer machine, Fresenius 4008S machine. In this is the control panel. Here we see the various pressure in the arterial limb, in the venous limb, and across the membrane. The blood is taken in from body to a pump. The pump in which anticoagulation is mixed, and from which this is pushed into a dialyzer. Here dialyzer is the medium flux dialyzer. Similarly, dialysis A and B solution from the machine is sent to the dialyzer in a counter current fashion for maximizing the clearance. After the clearing of the blood from the unit, the blood goes into a air chamber where any air bubble is filtered out, followed by into the patient. Similarly, in a patient, sorry, similarly in a patient in which we need high clearance of a larger molecule, say beyond 150 kilodaltons, we use HDF machine. We'll take a look at HDF machine. This is HDF machine. Here we put the HDF dialyzer, which we have seen, followed by here we put all the circuitry, and from which the blood goes to a dialyzer, which is put in place here. This is the panel from which we control all the dialysis and blood flow, from which high clearance is needed. Hope you understand. Hope you get to see the various modalities of the dialysis and able to understand it. Thank you. Thank you.
With that, we have completed the session now. Sir has briefly said us regarding the various techniques that have been used, and it was shown. So if somebody has any doubt, any queries, maybe we can discuss. If you want to know anything regarding the extracorporeal techniques, kindly unmute yourself and ask us. You can write it in the chat box either.
Any questions or queries may please be asked.
Maybe
Maybe, Madam, shall we proceed with the vote of thanks?
yes, yes, sir.
Yes, yes, sir.
Please.
Yeah. Please. Okay. So, a very good evening to all of you present here. So, it gives me immense pleasure to deliver the vote of thanks in the webinar organized by Vishwa Ayurved Parishad Agad Sambhasha. So I take this privilege to thank Professor Shivendra Singh sir, who is the head and in the Department of Nephrology at IMS BHU, who has taken out his valuable time to enlighten us about the extracorporeal techniques. At the same time, I would also like to thank Dr. Shaurya Sisodia, the senior resident from IMS BHU, who has given us a practical demonstration about the dialysis machine. Also, I would like to thank the executive committee members of Vishwa Ayurveda Parishad, Professor Govind Shuklaji, the president, Professor Mahesh Vyasji, the general secretary, Professor Yogesh Chandra Mishraji, the organizing secretary, Professor Anil Shuklaji, the Rashtriya Pramukh of Shikshak Prakost. I also extend my heartfelt thanks to the Agada Sambhasha team members. Special thanks to Professor Shobha Bhatt Madam, who is the convener of Agada Sambhasha, and Dr. Ashish Bharti Goswami, the coordinator, who has been working hard for conducting this event. I would also like to thank all the zone-wise coordinators of Agad Sambhasha team who have guided us and helped us in conducting this event. My heartfelt thanks to Mr. Suraj Kumar Maurya and Ayush Kumar, who are the students of Banaras Hindu University. At the last, I would like to thank all the faculties and the students who have attended this webinar and guided us and helped us in making this event a successful one. Thank you, one and all.